everyone. Welcome to our sixth CAEP COVID Town Hall. I can't believe that 6 weeks has passed already, although in some ways it feels like this has been going on forever. And it has certainly been an interesting ride here in Montreal, where the battle against COVID is truly being fought in the long-term care facilities. We've had a catastrophic number of fatalities in these facilities, totaling well over 1,000. And now the Quebec government has called in the army to help with the staffing shortages, along with a request for over 2,000 medical specialists to step in to help for the residents in these facilities. So it's definitely interesting times in this part of our country. Before I introduce our speakers for this evening, I'd just like to thank the CAEP Town Hall Committee members. We meet every week to go over current topics and the questions that come from you. And in this way, we decide on the content and the speakers for the next week's Town Hall. And then we track people down and organize it from there. So it's been consistent work, and I'd just like to thank this group that includes myself, Paul Pajot, Eddie Lang, Dan Colick, Rod Lim, Trevor Jane, Sean Moore, Patrick Mooney, Christina Bova, and Jeff Allen. And then I'd like to thank all of you for tuning in. So tonight we have a pretty cool lineup. The evening will be divided into 3 parts, and the evening will be divided into 3 parts. First, I will interview 2 emergency department doctors who have recovered from COVID, and they will talk about their personal experiences. And then Dr. Michael Scholl will talk to us about the epidemiology of COVID and what we might expect in the next 6 weeks or 6 months. And finally, we will end up the evening with Dr. Lori Mazurek and Dr. Dan Kolick, who will give us updates on PPE and aerosol generating medical procedures, respectively. We are going to start the evening with accounts from 2 emergency physicians who have recovered from COVID. They will talk about their personal experience. We have Dr. Cherie Nissen-Jordan. I already introduced her, and Dr. Joseph Finkler, who works full-time in the emergency department at St. Paul's Hospital in Vancouver. He's also spent time as a locum at almost every ED in the lower mainland of BC, and he was on call as a transport physician with the infant transport team based out of the ICU at BC Children's Hospital. He helped create the first ED-based eCPR program in Canada and served as the Associate Dean of Admissions at UBC. I just have to add this in, that his hobbies include interval training, magic, and bear watching. So we're in for a treat. I'd just like to start by asking Cherie if perhaps you could tell everybody a little bit about yourself, your practice, and then we'll go over to Joe and we'll get into the other questions after that.
Sure, Kristen, thanks. This is really very much of an honor to be with my Emerge colleagues. So most of you know me. I've done lots of international work over the years. I was pediatrician to start, pediatric Emerge then, and then actually sat on the emergency specialty board for several years, and really was very much involved with CAEP and the board from a pediatric emergency perspective. So I have near and dear thoughts about CAEP, and my practice now is I'm really weaning out of pediatric emergency in North America and really moving more so into global health. And there, it's really not restricted to pediatric emergency. I basically do everything, as everybody knows, that you end up doing in global health. And my most recent was the measles vaccination campaign in Central African Republic, where we came back literally the day that the Prime Minister said, you better get home or you're going to be in trouble. So that's how we managed to get COVID too. So I'll leave it there and let Joe to tell a little bit about his practice.
Sure, Joe, over to you for a second.
But first, Cherie, tell me where you came from. What country did you come from?
Central African Republic.
Oh, Central Africa, got you.
Right in the middle.
All right, okay. So I've been out here in British Columbia for about 25 years and did this family practice emergency program through St. Paul's Hospital. And then after about a decade or so in practice and doing locums in multiple emergency departments throughout the Lower Mainland, I ended up coming back to the center where I was trained at St. Paul's. And I've been here for about 15 years. And it's primarily adult-based emergency department, but we see a trickle of kids for sure. And then occasionally I do locums in remote areas where there's a need, and that's got to be scenic for me. So Tofino, Jasper, and Seashelt are on the line, and then unfortunately I had some other stuff lined up, but it's all been on hold because of the pandemic. So basically I do adult emergency medicine and some roaming to the smaller places to have a lot of fun.
Great. So Cherie, just to pick up where we left off, you were traveling back from CAR, and tell us how you ended up getting COVID. Do you know if you know where you got it from, and then what happened from there? Sort of the next phase of the story.
Yeah, so I'm kind of a bit of a benign case. We get back on March 18th. Came into the 14 days of self-isolation, basically at home because we were international travelers. We chose not to wear a mask on the flights. There were a lot of people that were wearing masks, but we basically adhered to the WHO information and just kept washing our hands and had alcohol-based cleanser pretty frequently. We arrived back. No particular symptoms. 8 days later, I got a little bit of a cold, runny nose, and completely lost my smell and taste. And that was the minute I said, this is a very unusual cold, but hey, whatever, it's probably a rhinovirus. And, I don't think it's going to be anything significant. So 2 days later, I called in and said, geez, I want to help out at work and I need to get back. And when they said, oh yeah, I think you need to do some screening. So you come back on day 14 and you're healthy. So I went to the website to do an assessment, and basically at the end, the bright lights come up and said, oh, you need to go in for testing. So we went into the drive-by testing. Again, I'm feeling perfectly fine. And test came back less than 24 hours later that I was COVID positive. My husband ended up getting the same type of symptoms, and we had one other person in the household that ended up with a little bit of a cold. So we then had to do the full isolation, but at no time was there any particular problem. And for those of you that don't know me, I'm 61. So there was considerable concern from some of our own healthcare providers that said, ooh, you could get a whole lot worse and we need to touch base with you a lot. But we were fine. We were perfectly fine, and everybody in the household is fine. I think there are more issues that affect some of the other issues that I think we're going to get into later in terms of income and mental health and that sort of stuff.
Great. Okay. So, Joe, I think your experience is a little bit different. Why don't you launch your story?
Yeah, sure. So mine was, I think, more cryptogenic, or maybe I was in denial because I'm a bit of a night hawk and had done a whole bunch of night shifts. And my symptoms came on in the third week of March, and I don't know exactly when, but I felt incredibly tired, which I attributed to doing a whole sequence of night shifts and then changing time zones after one day off and then doing afternoon and late evenings. So my first symptom was massive fatigue, as if I was walking against a headwind or somebody was pulling me behind, and this fog in my head like I had a hangover that no caffeine could cure. And I'd had a background of chronic cough from a post-nasal drip or something for over a month, probably 2 months, and it got a little worse. I didn't have fever until right in the end. Now, as Cherie said that she lost her sense of smell and taste. Okay, so I didn't notice that because we were wearing so much masks, and usually the emergency department or ED is pungent with either antiseptic or industrial cleansers, or it's got the body excrement. And I didn't smell that. I thought, well, that's amazing. The mask now filter out this awful smell. And so I was just working, going home to bed. What clicked in is the day after my last night shift. There was cherry blossoms on the street, and I couldn't smell the flowering trees at all, which you usually do. So mine went from slightly worsening cough to this massive fatigue, And then I got fever, chills, and night sweats on after my last evening shift. And it was really my kids said, "Dad, you should get tested." And I said, "No, I'm sure I either got bronchitis or pneumonia. I'll be fine." I also had this upper abdominal pain. I was just like totally out there, like saying this can't be the thing. It's got to be something else. And I was just praying this was going to be pneumonia so I wouldn't have to give up my shifts to my colleagues and I could be in the trenches and help out when the big tsunami came, which never hasn't come here either. So I went to a testing site, just like she said that she went to a drive-through, actually walked through. I didn't know you could drive. I got barked at, put a mask on, got barked at, show your care card. Someone stuck something up my nose, and then I went on my electronic medical record the next day, keep waiting for my results, and it didn't come back. And I thought, geez, I wonder if they've either lost the swab or it's not in the cassette. And I kept refresh. And finally, I phoned the virologist on call. One of my colleagues had said, she said, "Oh yeah, your test is in there. I'm going to call you with the results." And then a couple hours later, it was bad news bears. You know, it was positive, and my heart sunk. But at that point, I knew I had it. I mean, when I soaked the bed sheets, I had the whole thing, fever, chills, rigors. I put it together, the lack of smell, the funny taste in the mouth, the worsening cough. You know, I had it. And I just felt really, really unwell. But I never felt I needed to go to hospital. I mean, ironically, my buddy bought on Amazon for me one of those finger pulse oximeters and brought it over. And I measured 80%. I thought, okay, I'm not measuring it anymore, but it'll get better. So I just hung out. And I just thought that for me the trade-off was we had kids in the house that were older, and my partner, my wife, you know, they had to be quarantined and self-isolate. So there was a real spin-off, which I didn't really anticipate. And my younger daughter's a healthcare provider as well, and she immediately she could work as long as she was not symptomatic, but couldn't go out. So she was also in quarantine. So I felt super guilty and embarrassed. My colleagues had to pick up my shifts for a few days, and anyways, I trudged through it. So, but I did not need to go to hospital. At least I didn't think I did.
Okay. Interesting. So a little bit of similarity and some difference. Laura, you mentioned, though, that there was a more significant impact in terms of finances and wellness, etc. Maybe you could go into a little bit more detail about that.
Yeah, I can talk a little bit. So, as many of you know, if you've done MSF, you don't make a lot of money. So for 7 months, not much income. Coming back to, I think I'm going to go off and do some locums, or I'll help out with doing shifts. And basically, I was not able to. So not only was there no work to be done in the Peds Emerge because there's nobody there, but I couldn't offer myself up for locums where there were needs from a pediatric emerge perspective, or even a pediatrician perspective. So we've basically had, I've had no clinical income at all. And I know a lot of other people are suffering from that as well. But I also offered, once I recovered, which then took, so basically I was in quarantine till April 10th and could not offer anything up after that. The good news is that, yeah, I've had COVID now, so that makes me a little bit less of a liability, although reactivation, there are some questions about that. But the issue, and I'm okay with the loss of income, we can weather through that, but it's really that, Joe mentioned the embarrassment. It's not really, for me, it was, I've come from a situation where I was needed vaccinating 50,000 kids in 5 days, and I'm coming back to do absolutely nothing from a clinical perspective. I spent more time doing CME than I've done in a long time, and I felt very guilty that I couldn't help out. And so I found other ways to do it. I then phoned up all my friends and said, "Hey, I did pandemic H1N1. Is there something else that I can help with?" And yeah, I've now got 2 projects going on, but it's still not clinical and it's not in the emergency department. So I've linked in with my friends and colleagues to try and maintain that clinical expertise during this time, so that in case they do need me, I can still go back, help them out as necessary, both in the PICU as well as the emerge.
Okay, that's tough. So you're back in there now. You're working now.
So I'm doing administrative pandemic work. I'm helping to do some of the projects related to the alternative care centers and working up airport screening, whether for the government of Alberta and other projects like that, but not clinical work at the moment because there isn't any to do.
Right. Okay. And I think, it'll be interesting because we'll follow this discussion with Dr. Schul, who will talk a little bit about why that might be in terms of some of the epidemiology and factors around that. So now, Joe, you mentioned it affected your family. And I'm just kind of curious, for all the other emergency doctors listening, what kind of things might we have to expect should we come home with COVID?
So, Kirsten, they'll need to self-isolate and quarantine, and their quarantine period doesn't conclude until you're asymptomatic, and you have to be at least 10 days out from a date of diagnosis, and you have to be symptom-free, except maybe residual cough. And their quarantine then it went another like 5 days, which didn't make sense to me, but supposedly their sort of last contact with you. I don't know. So the implications that the family members who are in contact with someone's COVID positive have to be quarantined a little longer and have to self-isolate. And if they're a healthcare worker, like I said, my daughter's a nurse. She could go to work but couldn't go out or meet with anybody else. She had to be in quarantine, just go back and forth to work, so long as she didn't have a fever and was completely asymptomatic from all the other points of view. So yeah, that was a full. And then there was people. The other aspect for the family is, I suppose, very serendipitously, I ended up connecting with the media, and for my family, it was sort of like the only analogies are you're sort of a stain on the door, like we have the plague, and because a lot of people around us thought we were radioactive. I was radioactive, and if I'm radioactive, that means my family's radioactive. We're not coming near your place. We'll drop the groceries off at the sidewalk if you need, but please, nobody come out. And they're fine. They didn't have the disease, but people consider them radioactive. And where my wife works, which is Vancouver Foundation, the CEO of the company phones us, is there any consequences for us? Do we have to start doing contact tracing or test everybody at the corporation because your husband's been tested positive and you quit work just before this all happened? So I don't know, there was a lot of that sort of stuff which was completely unnecessary and unqualified. Even going back to work, actually, the first few days, my colleagues thought I was radioactive. Like they jumped back when I came.
Wow. Crazy. So would you have recommendations for those of us who have colleagues returning who have tested positive? Go give them a big hug.
Great. Supposedly you're immune. I've now been enrolled like 2 or 3 studies, and I've made IgG antibodies according for the BC Centre for Disease Control. I just think that's just the human thing, and I softened up on that. I mean, I think it's a disconnect from what we know in our mind and what we feel and we know for fact and what we recognize in our mind, our thoughts, our emotions, they're tagged differently. Oh well, what if he's just, even though he's cured, what are the chances maybe he's not? You know what I mean? That sort of thing. That's just human behavior. Yeah. I would say similar to what what's right?
So yes. I mentioned that our family, my daughter, we came back for my daughter's wedding. So it was canceled. We get COVID. Now her wedding is on Saturday. We're now finished with COVID, and we are still getting, even her new in-laws can we hug you? Can we, this is a pretty important family occasion. It's the first wedding in the family, and it is majorly affected by COVID. So I have some big things that I have to make up to my daughter.
Interesting.
Yeah, totally.
Joe, just a question from somebody in our audience. When you said that the pulse ox was 80, did you get oxygen? You trusted? You just say that? What was your your initial thought, and then just kind of you said you dismissed it, but were you worried?
No. Honestly, I was.
Did you feel air hunger?
For like maybe 30 seconds, I thought, like one of the nights I went to bed and I felt crummy. The day or two after the diagnosis, I felt really crummy and I was coughing through the night. I said, I thought, if I go on a ventilator, I'll hate it, but whatever. I'll whatever. I didn't care. Put me on the ventilator. And anyways, no, I honestly, I just measured it once. I thought, I'm not touching this thing. I'm going to get better. And I just hung out. It was okay.
Okay, good.
I'm lucky I didn't try it until I was well afterwards because I thought this is low. Anyways, I didn't want. I hate hospitals. Like I never want to be a patient. I'm happy to intubate. Now here's the funny thing. So I'm 10 days out and I'm out of quarantine and we have a stabbing come in and I'm on call for trauma. And there was no time for all of us to gown up. Like it just, he deteriorated so quickly with tension pneumothorax. And one of my colleagues says, Joe, get to the head of the bed. We'll intubate. So just with a surgical mask and gloves, and I just said, yeah, bring on the COVID. I mean, he didn't have COVID. He was stabbed, right? Anyway, so, I mean, they were happy to use me as the shield, you know.
And how do you feel about that? It's another kind of.
I bring it on. I'm kryptonite against the COVID.
Right. Sheree, do you feel the same way?
Well, it's interesting because I feel bulletproof. Maybe that's not the right one for an emerge doc, but yeah, I'm more than happy to step out there and do it. But then I think, most of us that have done global health have been exposed to so many things that our risk tolerance, and as emerge docs, our risk tolerance is way different than a lot of the other members of the population for sure. But yes, I have the same feeling as Joe.
That's great. So now that we have two kryptonite superheroes amongst us, do you have any, as we kind of wrap up this segment of the evening, I mean, any take-home messages, stuff that you want to impart to the rest of us? I mean, I work in the emerge, and we all are talking about the fact that we all will get COVID at some point, and it is definitely anxiety provoking for many of us. Just being off for 2 weeks, and then having, like you said, Joe, to give up your shifts and then not work and so forth, and then I guess wait for 2 tests before you can go back, and there you go. So, any thoughts for folks out there as we kind of wrap up? Sheree, you can go first.
I think that we do need to do some work as a profession, particularly the emergency group, because we're so dependent. And some of you are on alternative payment plans, so it doesn't matter if you see patients, but there's a lot of us that are on fee for service, and it does affect our income. So number one, a lot of us will take risks that we might not otherwise do if we had a steady, stable income. So one of the discussions points that I think we need to do is some sort of basic regular income that can allow us to continue and offer the services, because they still need us. They still need us for, even if it's only 20% of the population. We're finding that our acuity is way higher now. And so they still need us, but we're not making a whole lot of money doing seeing 1/5 of the number of patients. And that's if you can work, if you can have a shift. And so I guess we need to look at some sort of basic income.
That's a great suggestion. Yeah. And Joe, what are your last
So two points, Kirsten. Remembering there's a huge spectrum disease. Cherie's was almost like a cold with lack of smell. And then you have the people who are so sick in ICU, cytokine storm, fighting for the life of the respiratory failure, ARDS. And so people have to remember, not everybody gets the worst case. Those are probably the exception. The case fatality rate is actually quite low, and it might even be lower if we actually knew what the denominator, the reservoir of asymptomatic people, it might be like 1/10. So that's the one thing. The most positive thing that came out of this, and maybe Sri felt this as well, and maybe you always feel this because you're in global health, is that while I was sick and couldn't do very much, I ended up like getting involved in these projects, creating or trying to design and manufacture helmets for non-invasive positive pressure ventilation. And it's really not so much important about the project, but the what the community that was developed of people that came together from all different specialties to make a response to COVID was hugely amazing. Like, it's unbelievable. Through the American College of Emergency Physicians, I got in a cluster of people from the States. I got to speak to intensivists in Washington State. I spoke to emerge docs down there. When they found out they had COVID, they were phoning me to see how they were doing. I ended up connecting with an aeronautical company called McDonnell Detweiler and Associates, which builds parts for the shuttle and for satellites and aircraft, how to make these helmets, and they offered up services. I ended up getting involved in a super cluster of design engineers, researchers. I mean, it was so cool to see people from all different specialties and not even necessarily medicine coming together to develop projects for PPE, for screening devices, for antibody testing. It was just amazing. And I think that was the most inspiring thing, is to see that people linking arms, breaking down barriers, and to put a good defense against this pandemic. And I think, we're if we get pulled over here in BC, it's not because people didn't try. I think it's just, we'll be over-resourced, but I actually don't think it's going to happen based on the epidemiology. So I think that'll be the legacy of this, is people actually coming together in an amazing way to create solutions to deal with it.
Oh, that's a great way to end, and very positive note, and a good segue, I think, into our next speaker. So I'd just like to thank you two so much for joining, and certainly, if there's any next part or phase of your journey or story, we'll get you to feed back in the loop of our Cape Town halls, and maybe you can be a regular appearance. So thank you again, and I think what I'll do now is say goodbye and introduce our next speaker, who is Dr. Michael Scholl. So he is a CEO and senior scientist. Bye. See you again. You can stay on and listen, of course. You're welcome to do that. So Dr. Scholl is CEO and senior scientist at ICES. He is a professor in the Department of Medicine at the University of Toronto and a senior scientist at the Sunnybrook Research Institute. His research focuses on health service utilization, quality of care, health system integration and patient outcomes, and the evaluation of health policy. Under his leadership, ICES has expanded the types of data available for researchers, created a virtual data platform where researchers can access and analyze linked data sets, and launched a health artificial intelligence data and analysis platform. Dr. Scholl leads the participation of ICES in the Canadian Data Platform, a pan-Canadian initiative to build a national health and social data platform. He practices as an emergency medicine specialist at Sunnybrook Health Sciences Centre, and I'd like to say that he's even treated my grandmother in the emergency department there. So without further ado, I'll hand it over to you, Dr. Scholl.
Thanks, Kirsten. Do I need to share my screen? Jeff, I'm not sure if I share or you are controlling this. Okay, all right. So I think I've shared my screen. Can you see it now? Perfect. Okay, terrific. So thank you, Kirsten, and thanks to CAEP for inviting me to participate in this Cape Town Hall. It's great to have listened to the experiences of Cherie, who I've known for years, and Joe. And sorry to hear about your personal experiences with COVID. I was asked to speak a little bit about kind of what's going to come after all of this, after the COVID-19 crisis ebbs. And Kirsten sort of suggested I was going to give a very deep epidemiologic analysis. I'm actually not going to do that. I'm going to talk a little bit about some of the statistics and so on, but largely I'm going to talk about some of my own reflections on where we're at now, where I see ourselves as a specialty going in the short term, and perhaps over the longer haul as well. So let's see, why can't I advance my slides? Here we go. All right. So where are we right now? Well, as you all know, because you're living this, many provinces are still in the thick of managing the outbreak. And that's particularly the case in Ontario and Quebec. But most provinces are either past their initial peak or plateauing. And I think past the initial peak would be largely British Columbia and Alberta. plateauing, hopefully Quebec and Ontario. But especially in those two larger provinces, there are definitely significant brush fires that are still burning. And as Kirsten mentioned at the outset, that's particularly the case in long-term care centers in both of our provinces. What we have been very lucky to see so far is that our acute care health systems have not been overwhelmed. Our hospitals are still functioning well. In fact, in Toronto, the hospital that I work at, Sunnybrook Health Sciences Centre, has historically low occupancy rates. There was only a handful of patients in the ICU with COVID, and the emergency department has seen volume drops upwards of 40 to 50% of normal. So the hospitals are frankly doing fine. But what has been revealed are these major gaps in both the quality of care and the infection control capacity of the chronic care areas of our system. What is true though is that even within our EDs, which are seeing low volumes, the patients that are coming in are tending to be quite sick, and many of those are COVID-19 patients, but obviously not all of them. So it's kind of this interesting dichotomy with low volume but pretty sick patients, something that most of us, at least in the last 15 years or so, probably haven't seen as we've dealt with very large volumes over the last little while. So where are we as a country and compared to other countries in the pandemic? Some of you may know this fellow, Thomas Pueo. This is a graphic from a blog that he writes. And if you don't know it, you should look it up. It's very interesting. And he basically has drawn these figures. And if you look at I'm just going to bring up a slightly different pointer here. So if you look at the red line here, this is meant to be COVID cases if essentially a country does nothing to try to control it, versus this green line where you see the numbers coming down and then it's kind of bouncing up. And this is what he calls the hammer and the dance. And what that means is the hammer is this period here where countries impose significant physical distancing restrictions, economic shutdowns, major efforts at infection control, travel restrictions, basically what all of our countries are now doing to varying degrees. That is the hammer, which is designed to drive this red line to flatten it down into the green line, flatten the curve, that famous expression. But then as you flatten the curve and as cases start to drop, the natural inclination is for, in fact, the inevitable result is that countries will loosen the restrictions, the physical distancing, reopen economies, and so on. And as you do that, we will likely see subsequent waves of illness, coronavirus, and COVID-19 disease, which would be the dance. So these are these subsequent waves where numbers of cases will increase. Countries may then reimpose certain restrictions. The cases will go down, they'll loosen them, cases may go up again a little bit, and that's this sort of hammer and dance that he describes. And if you look at where various countries are, here we are, Canada up here, we think we're more or less at the peak and we're starting to come down on the other side. We hope we are. Certainly France and Germany, Australia, Spain, and so on, China are coming down that curve. But we're also starting to see in countries like Japan and Singapore, countries that initially were seen to have done a very good job of managing the COVID pandemic. Now they're starting to experience these secondary waves and are having to reimpose some of the constraints and controls that they had previously. This is another way of looking at the pandemic. It looks like a very busy chart, but focus on the colors. And this blue rectangle here in the middle, that's Canada. Okay, so every row represents a country, and this is Canada here in the middle. Green is basically low numbers of cases in the country day over day, and as it gets more into the yellow and the light red and then the dark red, that is increasing numbers of cases per day within that country. So the color is just basically relative to that country itself. And if you're a country where there's lots of green, it means you don't have very many cases. If you're in the yellow, it's starting to increase. Red means many more cases. So the countries that are up at the top here are countries that are really in the thick of the epidemic, that even today, this is dated 19 April is the last day here, they're still towards the peak of cases. And if you look at Canada, we're pretty much in that pack. So while we think we're plateauing, plateauing means you're at your peak. So we're still very much in the thick of it, whereas the countries down here have left the worst of the pandemic behind. And those would be countries like South Korea, China, Italy, and so on, which have been, well, especially in the case of Italy, very hard hit by the pandemic, but are now coming out the other side. So again, this is Canada here in the blue rectangle. We think we're at the plateau and are coming out the other side. That remains to be seen, of course. But when we talk about Canada, of course, we've got 10 provinces and 3 territories, and this pandemic, this outbreak is not the same in every province. If you look at the graph here on the left, you're seeing that the cumulative number of cases of COVID-19 in various provinces and countries since the 100th case. Here's Canada at the top, the red line. You can see it's looks like it's starting to plateau. And that's very similar to the Quebec and Ontario lines, of course, because the numbers in Quebec and Ontario are largely driving the Canadian numbers. But looking at Alberta, it looks much more like we're hitting the plateau. Similarly with British Columbia, Nova Scotia, and then the Maritime and Manitoba and Saskatchewan provinces look like they've hit their plateau quite a while ago. So again, different looking outbreaks in different provinces. If you look at deaths, again, similar sort of picture where it's much more clear that in Alberta and BC, the deaths have plateaued. In Ontario and Quebec, we hope they're plateauing, but we can't really be sure about that yet. And with the ongoing outbreaks in long-term care and with a very high mortality rate in long-term care, I think we're going to see a lot more death, unfortunately, in those provinces. Let me just show you a snapshot. This is from a couple of days ago, and this is reflecting the outbreak in Ontario long-term care homes. So these bars here represent the total number of long-term care homes in Ontario. So there's 600 and looks like about 640 long-term care homes in the province. And this is these are successive days. And the dark blue and the number represents the number of homes, long-term care homes with outbreaks. That means at least one COVID-19 case. So these are not individual patients in those homes. These are the actual homes that have outbreaks. And we've gone from 14 homes on the 29th of March to 127 long-term care homes on the 18th of April. About 3 weeks later, 127 homes with at least one case, but in some of these centers, there may be 50 or 60 cases of COVID-19. So this number is increasing. I don't think we can be sure that's plateauing. And within this 127, you're going to see outbreaks of varying intensity. And I am extremely worried about the outcomes for the individuals who live in those centers, for the staff who work in those centers, and of course those the people who work there don't live there. They leave that center, they go home. Traditionally, they often worked in multiple centers, although that's now been banned by the government. But obviously, there's a potential for these cases to lead to outbreaks either in hospitals or in the community. And just today, just as Quebec did, I think it was last week, the Premier of Ontario has asked Ottawa to send the military in to help support the staffing in long-term care homes. One of the in my view, one of the great tragedies of this pandemic is the impact on long-term care homes and the staff in those homes. And I think it will be a long time before we fully understand the extent of the hardship and horror that those staff are experiencing. So in sum, the current situation is that we're still in the acute phase of the COVID-19 response within Canada, but I think it's probably true to say that within a month or so, or let's say by June, we're going to likely see some sort of shift towards a relaxation of restrictions. In other words, lessening of physical distancing measures, reopening of the economy in some way, shape, or form. And so what is that going to mean for our emergency departments? Well, the truth of the matter is that I'm sort of looking into a crystal ball here, and I don't really know. I mean, I don't have any special knowledge or special insight into what this is going to mean for our ERs, but I can speculate with the best of them. So really, the next little bit of this talk represents kind of my own thoughts and some reading I've done and people I've talked to about what I think we can look to over the next couple of months. Well, the first thing to say, I think, is that we should not expect that that there's going to be just one wave. That even as we're coming down the peak, and even in provinces like Alberta and BC, where they seem to have well managed this first wave, and COVID-19 is now ebbing, I think it's very likely that it will flow again, and we will very likely see that dance with subsequent increases in cases in waves 2 and or wave 3. And I think the truth of the matter is that even if we come down towards the end of wave 1 and we get some sort of break before wave 2 happens, we're not going to, this may be gone, but it's certainly not going to be forgotten. And I think there's going to be a lot of residual anxiety, especially among healthcare workers, as well as patients and the public around the disease. We may be heading into a new normal, maybe. I'm not a big believer in this notion that everything changes and it's never the same again, but I'll talk about that a little bit more, what that new normal might look like. But I think the truth of the matter is that it's actually going to get harder as we come out of wave 1 to estimate the risk within our EDs, the risk of whether a patient has COVID-19, the risk to staff and so on, as opposed to it being easier. And why is that? Why will that be? Well, this is sort of a representation of what it's like right now in our ERs. Not a lot of people, a huge focus on the possibility of COVID-19. We're spending a lot of time with each individual patient thinking about COVID-19, looking for those patients, testing everyone pretty much. And so we're doing a pretty good job, I think, in the ER of identifying early the COVID-19 patients and making sure that they don't infect staff or other patients. But imagine when our ER volumes start to go up, and now you still have the occasional COVID-19 patient coming in, but they're coming into our usual crowded ERs a few months from now. How good are we going to be at being able to identify those individuals, at putting the same emphasis and focus on that versus everything else we'll be doing? How effective are we going to be at isolating those patients early, at always ensuring they're in a private room, at not leaving them in the waiting room for a few hours sitting beside other patients, potentially exposing them to a highly infectious virus? And so I think the risk, in fact, is going to be harder to manage down the road, even though the absolute number of COVID cases might be less. I think the risk with each COVID case to staff and to other patients might actually be higher. So what will it look like? What will my ED or your ED look like post-COVID-19? Well, we're going to obviously need to manage larger numbers of non-COVID-19 patients because the volumes will eventually recover, and potential COVID-19 patients at the same time. I think we're going to have ongoing risks of hospital outbreaks. So we've already had cases at my hospital and others of patients who've come in for surgery. They turned out to have COVID-19. Nobody realized at the time. They're on the surgical ward. It eventually is diagnosed, and you have an outbreak, and staff are off on quarantine, and other patients have been affected, or staff have been infected, and so on. We know we have ongoing PPE supply challenges. I don't think those are going to vanish overnight. We're going to continue to be probably required to use much more PPE than we did in the past. This is a worldwide supply shortage. Canada's ability to manufacture its own supplies is only ramping up. So I think we're going to have ongoing challenges with PPE that we're going to need to think about. We know there are potential drug supply issues, especially with respect to paralytics and sedatives and so on, drugs that are in high use currently for severely ill COVID patients. Again, I think those may well continue and possibly worsen. COVID-19 test availability, certainly in Ontario, this has been an issue. Our ability to test as many patients as we would like has not been where it should be. The protocols for who to test are constantly evolving. The ability to be out in the community during sentinel surveillance is still relatively limited. And so this is something that is going to continue to be a challenge even after wave 1 really has diminished. So I mentioned testing, and absolutely this is going to be, in my view, a keystone to our ability to adequately manage and prevent major outbreaks from occurring again in subsequent waves of COVID-19. So effectively reducing community transmission is going to require expanded testing. We don't understand the asymptomatic infection rate. We don't understand, even if you are asymptomatic and you're infected, what is the risk of asymptomatic transmission? I don't think we understand that truly. We keep talking about this 14 days, this magical 14 days period of infectivity. positivity, I don't think we know that for sure. And there are suggestions that people may shed virus for quite a bit longer than that. Whether that means they're infectious is another issue. We need to be enabling systematic surveillance and the identification of high-risk clusters. And this means really testing widely within long-term care centers, retirement homes, shelters, group homes, anywhere where there's congregate living. This is something that we're going to need to develop sophisticated strategies for testing. And then, we still have this major issue around rural, remote, and indigenous communities where testing may be difficult to ensure, where treatment is far away, and where you have a lot of vulnerable individuals. So that is something that continues to be a concern for Canada. As we manage, as we reduce or relax physical distancing, there will be issues about not just in the healthcare world, but in every domain of the economy. Who is safe to go to work? Who needs to be quarantined? And how is that going to be managed? As we ramp up testing, we're going to need to also consider reducing the turnaround time. Again, in Ontario, that has been a major challenge, probably less so in other provinces. There are concerns about the false negative rate of testing. If you're using it for diagnosis purposes, I think we've all seen cases of patients where we're absolutely 100% convinced they have COVID, but the test comes back negative. And yet, a few days later, they may have a positive test. Was it a false negative? Did they not yet have the disease? It's not often certain. And then finally, these questions around serologic testing. Joe was talking about the studies that he's in, but the truth is that we don't really know how to interpret serologic tests yet, and we don't know what immunity the antibodies that are present confers and for how long. So let me switch gears a little bit and talk about the impact on emergency department staff post-COVID-19. I think we're in this, it's interesting, Joe and Cherie were both talking about this sense of guilt that they wanted to be on the front lines with their fellow staff members, and they felt bad to not be involved. And that's I can totally get that, because I've been lucky not to get COVID-19, and I've been very happy to be able to work shifts along with my colleagues. There's this real sense that we're all in this together, that we're in the trenches, that we're on the front line, all these sort of military metaphors that are so prevalent. But what happens when that ends? What happens when the fight is over? Often there's a bit of a letdown. That sort of excitement, that adrenaline rush, it diminishes, and you can actually feel quite depressed at the end of it. There can also be sort of a post-traumatic phase to this, and I think different people will respond differently, both to the acute and the post-COVID phase. But I think we need to anticipate that some people will find it hard to deal with this, and we may actually see staff departures. You may see nurses, maybe doctors, who leave the practice of emergency medicine feeling that they don't want to have to go through this again. We also know from the SARS experience back in 2003 that healthcare workers who acquire COVID-19 at work and recover may actually be less productive and less likely and more likely to experience burnout and post-traumatic stress. This is just at least that was what we saw in the SARS experience, and that may be biased towards more severely ill individuals, because certainly SARS tended to be on average a more severe illness. But some of our colleagues who got COVID-19 will get quite sick. And so I think we have to be aware of that and look to ways to help them, support them as they re-enter the work environment. I think among staff in general, when you're in the middle of the COVID-19 response, you're immersed in it. You're in the trenches with your colleagues. You're doing what you're told. You're following the line and so on. But when that period ends, I think we can expect that there's going to be questioning of the response, questioning about decisions that were made. There may be some recrimination. People may feel guilty in one way, shape, or form about what they did or didn't do. And anxiety, even though the situation may seem to be more relaxed, anxiety may surface as the dust settles as a result of all of that sort of thinking and surfacing of emotions that have been repressed through the peak of the epidemic phase. So we should assume that there'll be flares of distress and anxiety as this goes on, as protocols break down. So you're going to see examples where people will probably not be following the PPE protocols as closely as they should, because they're just getting tired of wearing masks all the time. Or as new cases get diagnosed, including among fellow staff members, we will likely see flares of anxiety and this questioning and recrimination happening. So I don't think that's abnormal. I don't think it's a sign of any particular distress. I just think it's something that we should expect, and certainly for the ED chiefs out there and for other leaders, it's something to prepare for. So other changes, and not so much now about emerge staff, but just more in general. I think one of the things that we need to anticipate as the kind of acute phase fades here is, right now we've got this all hands on deck thing happening where everybody seems to be wanting to help out. You've got doctors from other departments who are offering to help in the emerge, folks up in the ICU helping out and so on, which is all fantastic. That's going to end at some point. The support from other services will end. For example, at our hospital, we have intubation teams that are led by anesthesia to support any COVID-19 related intubations. Well, those will naturally end. The sort of administrative support that's focused on many of our departments will end. We have extra staff, extra residents who are supporting. That will end. So all of that's going to end. And I think there may be a bit of a sense of abandonment that, it's not all hands on deck anymore. In fact, many of the hands will have returned under, below deck. And just think for a moment about when your ED goes back to being its old crowded self, about the challenge of managing suspect or known COVID-19 cases and how that's going to influence and affect staff stress. I think this is something that we really need to think about. Staff will be stressed about the patient. They'll be stressed about their own safety. They'll be stressed about the other patients that could acquire COVID-19. And you may be dealing with a full ICU again. And so what do you do with that patient if they're not doing so well, et cetera? So what about care and teaching post-COVID-19? Look, I think we're going to need to avoid ongoing use of PPE and distancing, changing physician-patient encounters. What I mean by that is, we're right now we're used to going to see every patient with a mask, with a visor on, perhaps with gown and gloves and so on. Some people I know prefer to stay outside of the room and call patients on their phones to talk to them, even if they're not 100% sure they have COVID-19. I think that we have to be careful that we don't allow COVID-19 to change the fundamental way that we interact, the sort of very human nature of interactions between physicians and patients. So that's just one thing I think we need to think about in terms of care. One thing that I think has been terrific as a result of COVID-19 is all of the innovations around virtual care. So the many examples now of both on the outpatient setting and family practice and so on, of physicians being contacted by video link, but also even the emergency department. We now have trialed video backups of physician assistants by emerge physicians in our emergency department. And I think that is something that I hope will become permanent. I think that's great innovation. What about face-to-face rounds and meetings at the hospital? We don't do those anymore. They're all virtual now. Well, maybe they should remain that way, or at least for some time to come, or a hybrid, or maybe permanently. I mean, when you think about it, if COVID-19 or the next COVID coronavirus that comes around, if you have a meeting where you have 20 or 25 emergency physicians in the same room, and if you're in that room, you could be quarantined for 14 days thereafter, is that a risk worth taking, or should we be looking to virtualize much more of our rounds and routine meetings? And frankly, for an organization like CAEP, I think, and for every organization, frankly, it may be time to radically rethink the risk and benefit of big face-to-face conferences, of weekly teaching days for all residents and all staff and so on. There is a real and measurable risk to those events, and I think we have to think that through. So I mentioned the new normal. Well, what new normal would I like to see come out of the COVID-19 pandemic? Well, here's one wish that COVID-19 can do for hand washing what HIV/AIDS did for condom wearing. Let's hope that we all continue to wash our hands like crazy when we're in the emerge and seeing patients, and even frankly in our day-to-day lives. Let's hope we see a permanent change to attitudes regarding working while unwell. I mean, I was fascinated when Joe was saying that he had hoped that he only had pneumonia as opposed to COVID-19 so he could keep working, and thought, wow, you would continue working if you had pneumonia. I mean, I'm not criticizing him. I'm just saying that is a very common attitude in our world. And I think that that's something that we really have to rethink, and we really shouldn't be working when we're unwell, COVID-19 or not. May we have better designed and reusable PPE? Can we go on, with the environmental cost of all of this disposable equipment, and often not as high quality equipment? Can we look to a world of better designed and reusable PPE? And can we rethink the ways to enable family and caregivers to interact with COVID-19 and other isolation patients? I think that one great tragedy that's coming out of this is the many, many patients who are having to suffer alone in isolation as they get very ill with COVID-19 in hospital, and now are, as you well know, in some cases dying alone. So in terms of thinking about this, is COVID-19 a black swan event? Is it one of these events that happens, basically one time only and is very unlikely ever to happen again, like Chernobyl? Or is it a predictable recurrent event like seasonal flooding? And I think if you look at the history of pandemics, and this graphic just kind of goes back to the year zero and highlights a whole range of pandemics. And here, this last bit up here is the last, say, 200 years or so. You see there's been lots of pandemics. I mean, even if you start back in 1918 with the Spanish flu, the size of these particles here represents the number of deaths. So 40 to 50 million deaths from the Spanish flu, the Russian flu back in the 1800s, Asian flu in the 50s, Hong Kong flu in the 60s, swine flu, SARS, MERS, HIV, AIDS, and so on. There have been a lot of pandemics, and not all as harmful as let's say the Spanish flu. But here, let's look at this. This graphic was made on March 17th, when there were about 7,900 deaths associated with COVID-19. And today, there are 177,000 deaths. So just over a month later, we've gone from 7,900 down around here to 177,000 deaths. So the ball for coronavirus now is almost as big as the swine flu. And we know for sure that this 177,000 is a major underestimate of the total number of deaths. So my argument would be, if I looked at this graphic, I don't think that COVID-19 is a black swan event. I think this is a pretty regular recurring event, and we can expect more pandemics to come. So big problems often require big solutions, and pandemics are big problems. And this got me thinking, especially with the analogy of flooding, got me thinking about the Red River floodway in Manitoba, which is built to control seasonal floods of the Red River, which would threaten Winnipeg and cause massive flooding in Winnipeg year after year. And so back in 1962, that's a long time ago, the politicians in Manitoba conceived of digging this massive floodway. And at the time, this project was larger than the Suez Canal. It was second only to the Panama Canal. It cost about $500 million at the time. It was built by a province which at the time had less than 1 million people in total population. Huge criticism of the decision to build this floodway. But since then, there's been a cumulative savings of about $40 billion in flood damage over the years. And I think this is the kind of big thinking that we need in terms of managing pandemics. It's the kind of big thinking that as a society, I think we've become very poor at maintaining, at achieving. We seem to shy away from it, big government action. But I think we need this with respect to pandemics. So will COVID-19 help us rethink our healthcare system, our ability to manage crisis and not sort of exist in a perpetual crisis of max capacity? Well, I hope so. Certainly, we need to think about expanding to have adequate inpatient capacity, coupled, I think, with effective and integrated community care. We need to have proper planning, real planning, to manage disasters and the next pandemic. And we need to have the stockpiling of proper equipment and ensuring training. Of course, many more things than this in terms of our healthcare system. But beyond the healthcare system, will COVID-19 also help us to rethink our society? And I hope the answer is yes. I certainly hope that Canada will rethink its approach to elder care. The way that we have institutionalized long-term care, elderly folks in long-term care facilities, I think has been revealed to be the problem that it is. And that's not to suggest that the staff who work there aren't dedicated and loving and working under very difficult circumstances. But I think we really have to radically rethink this way of caring for elderly, vulnerable individuals. I think we needed to ensure that there is advanced planning directives at scale that are normalized, a reform to medical assistance in dying. For example, the ability for individuals who are in early stages of dementia to indicate their advanced directives in advance. I think to the ensuring appropriate infection control and symptom management, including proper palliative care in these facilities, is going to be critical. And for staff, I think providing living wages and greater value to the work that they provide. Will COVID-19 cause Canada to reinvest in public health in ways that it should have many years ago? Will it cause us to invest in affordable housing for vulnerable populations and the homeless, who we know are very vulnerable to this outbreak? And what about basic income supports? It's interesting, as the government has rolled out so many economic support packages, that we're starting to talk about basic income again in a way that I think is very interesting. So I'm going to stop there, and I think take questions at the end, or maybe now. I'm not sure. Thank you.
Thank you so much. I hope that you can hear me. That was a fascinating talk, and I think very timely given what is going on right now and questions that people seem to be asking. I think it certainly answered many of mine. A couple of questions from our audience today, and one that I think is pertinent certainly to Quebec is why do you think the other provinces did not have outbreaks in their long-term care facilities that we see in the other provinces?
Well, it's a good question. I don't know I have a great answer to it, because I don't really have a lot of insight, frankly, into what Alberta or BC in particular did. I think a couple of things, though. I mean, for one thing, there are just smaller outbreaks overall, so there are fewer opportunities, I guess, for there to be exposure within long-term care facilities. And you know, it may well be that some of the measures that were put in place, I think it's true, although I don't know for a fact, but I believe that BC instituted a rule where staff in long-term care facilities couldn't work in more than one facility earlier than Quebec or Ontario did. So I think that's a very important measure. And then I really cannot speak to the state of PPE supply and infection control practices in other provinces. I can say in Ontario that I think it's demonstrated weaknesses and inadequate supply and training probably in many of our facilities.
Wow. Yes. No. It's true, and it's a good point about healthcare workers only being allowed to work in one institution and not move around. A couple of the questions kind of lumped together in terms of testing of healthcare workers. I mean, do you see a future where healthcare workers are going to have to be tested sort of regularly? And another question was. I don't know if you've had a chance to read the recent JAMA article, but that healthcare workers with COVID are working an average of a couple of days with or without symptoms. It says here that the JAMA article specifies that they were working with symptoms. But what are your thoughts around reforming kind of our practice of working when we're sick and also being tested? It seems a bit violating, actually, when I think about it, going to work and having to be tested for COVID regularly or something like that. But do you think that's a new reform for emergency physicians?
I think that the reality is we're going to have more widespread testing of healthcare workers. I would be a proponent of that. Now, I think the test itself is imperfect, so I think there is some issues there that have to be addressed. But given how infectious this illness is, given what a risk we can present to our patients, I think that I'm not a big believer in letting people have just say I refuse to be tested on the basis of my personal liberties. To me, I think that if we're going to be safe, if we're not going to be exposing our patients to danger, and we know just how infectious this illness is, that there's no question that healthcare workers are going to need to be tested more widely.
Mm-hmm. And I guess the last question is around when we're getting back to normal, when hospitals, reopen up, and we have this phenomenon of patients who have not been able to get their biopsies for cancer, for tumors, for surgical treatment of their diseases that they have been waiting. So we're going to be bombarded. But then we've got to juggle this with rooms being patients not being lumped into same rooms, and the increased cleaning times. There was somebody said that it takes about 50 minutes extra between each surgical intervention to clean now with COVID. So how do you foresee that impacting the emerge in terms of bed block, and how do we manage and mitigate the negative outcomes of that?
Yeah, well, interesting. I don't know. I think the reality is it's going to be tough. I mean, whether we see we're going to see volumes go back up. Are we going to see them go above what they would normally have been? Is there some kind of catch up? I don't know. I mean, I don't think people are waiting to have their heart attacks. Either they're not having their heart attacks or they're having their heart attacks and not coming in. But I don't think they'll suddenly start having heart attacks again a month from now. But there may be other more chronic conditions that people have been waiting to come in and so on, and will be. So there may be a bit of a catch-up phase. But for sure, I think that that's the point I was making earlier, that if you've got to be managing potential COVID cases beside your run-of-the-mill emerge patients, you've got to be finding some way to isolate those patients, and that is going to require a change in our usual practice. It's correct about increased cleaning. I mean, that's going to be the same in the emergency department as well. And I think we are going to struggle.
Yeah, yeah.
And then the other thing I would say is, if suddenly you get a second wave, like we could see a sudden surge in cases again, and you don't have. I mean, we had weeks to plan and prepare for this because we could see what was happening in Italy and elsewhere. We may not have the same luxury for a second wave.
Yeah, for sure. There was just one final question that flashed up in front of me, but I didn't have time to read it. So if that, yes. Super. Thank you very much. So the last question is that Lori, it was Cherie actually. Michael, did you find any information in the literature regarding the speed of volumes of recovery in emergency departments after the wave is over?
No, I can't answer that question. I mean, I see there's a comment that Lori Mazurek has made about the non-COVID surge in Wuhan. So perhaps Lori can answer that question when she comes on. I don't have a good answer for that.
Well, that's a great segue then. I would like to thank you so much for putting this together and for giving such a fascinating talk this evening. And so with that, I think we'll move on to our last two speakers of the evening, and that is Dr. Dan Kolek, who you have the pleasure of listening to before, and Dr. Lori Mazurek, both of who have been on our CAEP town halls. So just a little brief intro, a plug for Dan. He's an award-winning emergency physician, an assistant clinical professor in the section of emergency medicine at McMaster University, chair of the CAEP Disaster Committee, and the executive director of the Center for Excellence in Emergency Preparedness. His papers and publications and presentations have spanned many disaster-related topics such as terrorism and CBRN readiness, and he served as the emergency department chief and program director in both Hamilton and Kitchener-Waterloo. And Dr. Mazurek is based in Toronto, and she's had over 25 years of experience as a critical care transport and emergency physician, and she has expertise in PPE and conducts disaster exercises to inspire interprofessional teams to find solutions to healthcare shortages. So she's been a consultant to the Ontario Ministry of Health, Public Health Agency of Canada, Global Affairs, and the World Health Organization. So without any more delay, I'll hand it over to the two of you. And Dan, you're up.
Thanks very much, Kirsten. Let me just bring up my screen so we can share. Okay, so you should have my screen. We're going to be talking about aerosol generating medical procedures in the COVID era. And just to summarize quickly what the topics are, we're going to go over droplet versus aerosol. What is the difference? Aerosol generating medical procedures. So what should we be wearing in terms of PPE? Which procedures are non-aerosol generating? Again, what should we wear? Which ones are unclear? And that's where we're going to have our biggest conundrums of the night. And then we're going to go into specific scenarios. And that's where I'm going to hand off to Lori, who's going to walk through some of these and talk about each case, what to do. There is a summary on the CAEP website of all this information, including an outline of scenarios. So if for whatever reason you want to have a written summary, it's all available there. This is quite the shift from the macro that Mike was talking about to the micro. So let's go as micro as we can get, and we'll talk about droplets. Usually the coronavirus is disseminated through droplets. And the difference between droplet and aerosol really is basically the size of the particles. For purposes of definition, one of the definitions I found was 5 microns. The bigger the particle, the less time it's going to spend in the air and the less far away it's going to go when it's leaving the patient. So at 5 microns, the range is typically 2 meters, and then it drops. Whereas less than 5 microns, it'll stay suspended in the air, and it can stay there for 3 hours. The stuff that drops and hits the surface, you can remove that by cleaning. The stuff that's in the air, really, the time it's there is going to be to some degree a function of the air exchanges in the room. Both cases, doesn't matter, droplet or aerosol, need gloves and face shield. Non-negotiable, that has to be there. Where they differ is in the kind of gown you need and the kind of mask. For the droplets, you need a droplet protective gown and a straightforward surgical mask. But once you get into aerosol, you need a level 2 resistant gown and an N95 mask. Let's look at a few specific situations. What are the procedures that are known to generate aerosol? Certainly high flow oxygen therapy, whether it's more than 5 liters a minute by nasal prongs or 15 by Venturi. Non-invasive ventilation, which includes CPAP, nebulizing for sure, any manipulation of the airway, intubation, extubation, suctioning, tracheostomy, bronchoscopy, and so on. Now, once the patient is intubated and you've got a closed circuit, in other words, you have no open-ended tubing, and there's a viral filter in line, then you can go back to droplet. It is the act of intubation that is the issue, okay? And I should also point out that LMA is not equal to intubation. LMA is a temporizing maneuver, so it is not really 100% protective. Oops, sorry. So for those items that are aerosol generating, it's pretty straightforward. We know we need airborne precautions. For those items that are non-aerosolizing, so lower flow oxygen therapy, if you're doing an NPS or a throat swab, chest tube, either insertion or removal, with the exception of if it's an emergent insertion, pneumothorax, trauma, and so on. Regular oral hygiene, which is not the same thing as oral suctioning. Any procedure with local anesthesia, which sort of makes sense. Chest physiotherapy, with the exception of breast stacking, because with breast stacking, you're going to have that long, powerful exhale. And then giving intranasal medications such as naloxone. So these are non-aerosolizing. And in this case, really, all you need is droplet precautions. This part is clear. The part that we get into where we have a problem is where it's not clear. And the thing with any of the items on this list, I can find categoric statements by good authorities saying both one way and the opposite. So ventilator circuit disconnect, some people will say it is an aerosolizing environment, others will say it will not be. Chest compressions with a non-intubated patient, oral suctioning, defibrillation for a non-intubated patient, thoracostomy, things of that nature, or nasogastric tube insertion, we don't really know if they're unclear, if they truly are aerosol generating. And the difficulty here is that you cannot prove a non-event. We can say that we haven't identified aerosol in the environment, but that's a far cry from saying that there is nothing there. We can just say we haven't been able to identify it. Now, this gets complicated even more because it becomes a function of community prevalence. For example, if there's no community prevalence, no community transfer, then your risk of having COVID a priori is a lot lower. Normally, with a bag valve mask ventilation, it's considered aerosolizing. But if you're doing neonatal resuscitation in the code pink, then in that case, it's standard of care because there's no evidence of vertical transmission. So you have to nuance your understanding of what any of these events might be in terms of risk by how prevalent things are in your community. Now, I'm going to hand over to Lori here, and I'm going to let her go through some scenarios, and I may leap in later, and certainly we can take questions.
Well, one of them actually is maybe even from my group here, because there was some discussion that was generated from your the statement that was recently released by CAEP on aerosol generating medical procedures. And it says CAEP seems to have changed their recommendations that oxygen by nasal prong greater than 6 liters or 15 liters NRB is AGMP. Do you feel this recommended should be adopted Canada-wide? So I think it was 6 before, and now it's 5.
Well, it's over 5. So I don't really think that we have any science that'll say if you go a liter up or down, you're going to make a big difference. I think it's a little bit of a nominal choice. If there's someone out there who works with oxygen flow and is more of an expert on this than I am, by all means leap in. But the concept is that of high flow. If you want to pick 6, I don't think, first of all, I don't know if our measurement is that accurate to begin with in terms of how much oxygen is being delivered to the tubes. And if you want to pick 6 versus 5, I think that's a trivial difference, a relatively trivial difference. I'm willing to be told I'm wrong, but I don't think it's as big a deal.
So can you hear me now?
Yes, great.
Okay, I don't know if I have to log in, log out. Bit of an echo.
I'm going to.
All right. So Jeff, I'll take those slides. Okay. I will say there is still controversy about aerosol generation, especially in, I don't know why there's an echo here, but in some of the things like high flow nasal cannula where you have 30 to 60 liters per minute. For most places, they have found that it is safe and staff using airborne precautions in a negative pressure room are not contracting the disease, which is reassuring, but it's still a lot of flow.
Sorry, Lori, your sound is kind of choppy. I'm not sure if you can just adjust your microphone so that we get a more consistent sound, please. Thank you.
Okay. So one of the things is where when you encounter a patient with vital signs, it is possible to encounter them and not PPE. And
Lori, it's still very choppy. You go in and out. I'm not sure if you can just do something. I'm not sure if that's your headset or the sound itself. Sorry.
So one thing is to find out what are bystanders being told to related to CPR, and I think it's something everybody should look at their own jurisdiction about. I think at minimum, if somebody I know or I came across someone in the street who suddenly collapsed via safe, I would take the risk of doing CPR, but I would certainly cover their face with their hood or something else and try to do it. It might be futile, but I have been found in bystander CPR twice, and both times people survived to leave the hospital, so I would be encouraged to do that. Within the hospital itself, I think everybody now is at minimum wearing a surgical mask, so your chances of encountering a vital signs absent patient without some form of PPE on would be highly unlikely. So I've lost the PowerPoint now. If you have only a surgical mask on, it really, you can do chest compressions and you can do defibrillation, but the recommendation is really to do ABCs during a pandemic and address the airway first because it's your safety. So you would cover the airway or secure the airway. If it's just you alone, as you're calling for help, you can cover the person's face with whatever's available. Presumably, if they are COVID, they have something on their airway, either whether it's a mask or like a surgical mask or actual an oxygen mask. And if not, you can cover with whatever there is. You can start chest compressions while you're calling for help. The next person should be in with an N95, as well as all their other precautions, so that they can put the patient perhaps on a defib and also bring in airway equipment where they can do the two-handed seal with the BVM over the airway. While you're doing chest compressions, it does mean that you're going to have to sort of break, if there's just two of you, you're going to have to break CPR to do the two ventilations, because that one person is going to be dedicated to the securing the seal with the BVM. And finally, if you have the full droplet sort of gown, gloves, etc., and you have the N95 on, then you can do all airway procedures, including intubation and BVM. BVM, I think, is generally felt to be the highest risk. If you have a poor seal, you're likely to cause leaks under pressure, and these are felt to still be high, patients with high viral loads. So your chances are spraying virus to everybody for sure very close within that 1 meter is high. So that's why the dedication is to the airway to protect the team. Essentially, yeah, no PPE, no CPR, but I will say that people are probably inclined to start CPR, but the main thing is knowing the risk of that and first address the ABCs, cover the airway first. The outcome of just CPR alone, fairly quick additional sort of intervention typically not be that good, but there are instances where people knowing the risk, and it would be useful to know what your dispatch is actually telling people, because we're certainly having cardiac risks in the field, and to know whether or not you're advising people to do it and what they're telling people to do about the airway. So next slide. So this is just a summary of what we already discussed. It does show a person with a mask. You got to make sure if they have a surgical mask on, it's actually up higher. It should fully cover the nose. You can do chest compressions. It's felt that it's safe to do chest compressions and defibrillation with just a mask on. So you could potentially do all of this by yourself while you're waiting for help, but you have to have some sort of defib apparatus ready. And I would like to think that if you're in a hospital, that people will be coming fairly quickly. So next slide. As soon as you're doing BPM, you really need to have the N95. So whoever's coming in with the BPM should either allow you to step out to get your own N95 on, or more people coming in that are appropriately dressed. Assume those responsibilities as you step out. Next slide. Generally speaking, you're going to get a lot of people showing up, and what you don't want is everybody in the room, because they will, one, consume PPE, and it's an unnecessary exposure of people to the virus and high-risk procedures that may aerosolize the virus. In general, once the airway is secured, probably 3 is all you need in the room, because if you're intubated, let's say, you just have to bag every 10 seconds, and so there's enough people in the room to rotate to do CPR. Keep in mind that paramedics can do this with 2. So when we have in hospitals, I've made teams of 10 in some hospitals to do this. This is not sort of following the general concept of reduce the number of people exposed to. So you minimize the number, and those that are in the room get the N95 plus the other PPE. The others outside will be in the surgical masks that they should always be with all their other equipment, and have N95s readily available, so if for some reason they're called in to assist, that they can quickly don those, but not don them until they're actually asked in. One of the problems we had early was created when EMS was coming with we thought was a VSA or a pre-arrest patient, having far too many people dressed, far too many people wanting to be involved, and it consumed a lot of PPE. And then oftentimes we really only needed about 2 people instead of like 6 or 7 that we were addressing. So one of the things that has come up many times is, can you reuse N95s? I think Daniel sent me I'm not sure if it's a paper or a government notice from Quebec saying that there's no evidence to support that this is in fact safe. I would say that there actually is. One of the studies was done at the University of Manitoba in conjunction with the National Biology Lab in Winnipeg, which has all the most deadly viruses in the world housed there. And so they were actually able to use SARS-CoV-2 plus other viruses to take a look at whether this is in fact feasible. And in fact, it is. So what they found is that these are just scientific terms. One I think you'll recognize the most is autoclaving. But in your hospital, you will have all these things available. There are different forms of sterilizing different equipment in the hospital. So vaporous hydrogen peroxide, which is just hydrogen peroxide that's sort of, I think, heated to make gas. Peracetic acid, which is probably almost something like a vinegar. I have no idea, dry fogging. But autoclave, I'm sure everybody needs. And what they found is that they sterilized the masks, and what they did was put the virus on. They put them through the process, and then they actually tried to extract the virus from the fiber itself and try to grow it, and they found that there was no growth and no residual virus left on. And they could do this up to 10 times for the mask without either structural or functional integrity being lost. The exception was molded, so the pictures there are the molded ones. Molded N95 masks could only tolerate 1 cycles. But if you had a folded or I can't remember, like a bivalve type of mask, there was no problems with that. And other the vaporous hydrogen peroxide and the peracetic acid, you could use for molded ones, and they would we have to go through more episodes of sterilization. So is anybody actually using it? Well, absolutely they are. It was a big here in Toronto of running out. A couple of weeks ago, we were told that we had 2 weeks supply. After months and months of them knowing that we were running low, they finally said we have 2 weeks. Our provincial government got online and managed to get more masks. So it's not as big as the threat. But when the University of Manitoba came up with its sterilization and reuse process, our hospital plus many other hospitals in the Toronto area took it to heart, and they chose autoclaving, and they found that I can autoclave them safely. So currently, we are still doing this. At the end of your shift, you've used an N95, you put it in your own individual autoclave bag, and you write your own name on it. It's sealed. These are collected, and they go through an autoclave process. And apparently, they get 400 masks in an hour and a half. The idea is that we're going to use these now, but if we run out, you are going to get the mask that your own mask that you sterilize back for your own personal use. I think originally they were talking about collecting these en masse, so there was just a bunch of N95s, and you would know because you got back. I think a lot of people felt apprehensive about that, although the outcome might be the same. It's sterile, you don't have to worry. But I think psychologically, knowing that mask that you get back was on your face is somehow a little more comforting. That it's sort of like sharing underwear. I don't really want to do that, even if it's been laundered. But I'm okay with having my own mask cleaned and returned to me. And so I think there now is an acceptance that we will be happy to use these. Well, not happy because it means we've run out. But if we do have to, we have a process in place that's safe, that can be done in a way that will really extend our capacity, and we feel confident that it is safe and the integrity of the mask is preserved.
Laurie, I'm going to leap in just with some very brief comments, just overarching. We need to keep in mind that these patients have an abysmal survival rate if they arrest. In a review from China, 300 plus patients in hospital cardiac arrest, only one had survival to good neurologic outcome. So I think not only in the spirit of preserving PPE, but in the spirit of not doing things that are futile, if we see a non-shockable rhythm, we need to consider not intervening. The other thing is, for those of us who are base hospital physicians, if someone has had a long enough resuscitation in the field, we're not always those of us, I'm not a base physician anymore, but when I was, not always comfortable pronouncing in the field, but I think we need to be more comfortable if we haven't achieved ROSC. And the final thing is, if a patient arrives VSA, before the whole team gets suited up, the physician should get into PPE, go out into the ambulance bay, and assess the situation and make a call to a nurse who's in line of sight to tell them we're bringing this patient in, or no, we're pronouncing here in the ambulance. Let's not contaminate the department. Let's not put people at risk, and let's not waste PPE. Those are just my sort of overarching comments to that.
Yeah, definitely. That is one thing I think CAEP should look seriously at, especially as there is a significant concern about a wave 2 being worse than wave 1, that we should have in place. Should we even be doing CPR in the if we were as overcome as like New York and so forth? I think we sort of toyed with what that means and what it would look like, but what we should do is anticipate there could in some time be a need to have those recommendations in place, and to know what is our threshold for converting that to medics arriving and just confirming VSA, call a body removal, that type of thing.
Great. Listen, I'm going to jump in. There's a few questions, and so a lot of them actually have to do with aerosol generating medical procedures, but perhaps this is one for you, Laurie. There was one on what does CAEP, okay, so, well, I'll just start here. Is heavy spontaneous coughing considered aerosol generating? So if you're in a room with a patient who just breaks into a coughing fit, what's the deal with that?
Well, there is science that shows that, in fact, the cough can generate aerosols, for sure. And there's been ongoing discussion back and forth, especially with mid-turbinate swabs. I didn't realize how much vigorous coughing you can trigger. So I think the fallback to that is just like covering an air for CPR, that you put masks on patients and take certain strategies. If you are going to get turbinates, that they do have a mask on, you warn them to pop into their mask and turn away. So I think that even though they generate aerosols, we are capturing their aerosols by putting masks on them.
There has been some good science to show where they put people in a device that monitored what was coming out of their mouths and had them forcefully cough. And there's no question they can generate an aerosol. But the question is it clinically relevant? Yeah. And can we just stop it with a towel? That's probably good enough.
Okay. Yeah. I mean, you know, those intubation boxes, which I actually think are a waste of time, but it's almost like we should be using those, something like that, when we're doing mid-turbinate swabs. Like that would make sense, like a barrier that you know you're going to trigger a cough. So I think maybe more creative use of that word.
It's really 9:48, so I won't get into a debate about the intubation boxes. There are studies to show that they do have some value.
Okay, so just a couple of other questions. Does it make sense to make a hard and fast difference between aerosol and droplet as it is spectrum? And would it not make more sense to quote aerosol or dispersal distance instead?
It's going to be difficult to define that. I mean, you have to have some sort of, you're making a binary decision, which is what kind of PPE are you going to wear? Yeah. So what are you going to do? Have a halfway surgical to N95? So you have to have some kind of binary division where you decide at what point do you consider it aerosol. The fact that it is a continuum, that's absolutely correct, but your decision isn't. So I think you have to have some sort of divider in your head that puts into two categories.
And yeah, I think we know that there's intubation is always associated, although now that we go right to paralytic, you have to wonder where that transmission rate really is. And I think where the gaps are in our PPE is that we're not recording what people are wearing, we're not recording who's getting what. And that's, I think, the gap. Just knowing that the aerosol is one thing, but maybe we're getting it because you're all sitting in a lunchroom with no social distancing. So those kinds of things are not being well looked at. I still think we have to go back to the poor evidence of 2003 MERS. You know you go in the hospital to probably give that, and then get better models for aerosol generation, like whether they're putting out plates that capture the virus or something like that. We have these patients now. We should be doing a lot more of this testing, not just on the treatment, but on what the risk is to healthcare providers.
Yes, of course. And I guess just a couple quick last ones, and then we're going to wrap up. And so this came in quite a bit earlier, but does CAEP recommend covering does CAEP recommend neck covering and head covering for aerosol generating medical procedures? And then the last one is curious if any other small EDs, hospitals without an ICU or an RT are planning for early arrest airway management with SGA plus filter with all staff in AGM PPE rather than intubation, only intubate if ROSC.
So I think that came up in those questions came up in the PPE session before. So could a neck cover, or they're just not available. They do provide better protection. So making a recommendation for things you can't get isn't a very wise decision. If you have them, wear them. But most people don't have them. So that's the importance of the face shield, tying your gown up high. And after you doff, to actually wash or sanitize your face and neck. Because there's clearly you get contamination in the neck. Well, if someone coughed directly at you, you would get contamination in the neck for sure. So that's what you do with MERS, even though they have goods. So I think that's the one that you recommend. Wear it if you got it, sanitize if you don't, or any if you do have. What was the other question?
Yeah, and Lori, your sound is still so choppy. So
Daniel,
Yeah, maybe Dan, you can just field that
Sure,
last one.
I'll just,
Yeah, go ahead.
we don't have them. So if we don't have them, there's not much sense in recommending them. It is certainly true, the more we cover up, the less we're going to get exposed. I would love to have a hood that covers my neck, but since I don't have it, I'm not going to start worrying about that. What I do instead is when you clean up afterwards, I have applied more Purell to my neck than in the past while than I have in my entire life, because if I'm in an environment where I think I'm going to be exposed, I can't cover it. I'm going to have to clean it. So the answer is yes, it is better. No, we don't have it. Got to do something else instead.
Okay, well, great. And any last point about the managing an arrest area with a supraglottic airway and filter instead of intubation?
Recognize that the supraglottic airway is not as reliable in terms of blocking aerosol as intubation. It's certainly way better than nothing, there's no question. But depending on the model, sometimes you have to have them with a bit of tension held in place. So you have a pair of hands sitting right there holding that thing in place. Those hands are going to get contaminated. It can displace, and the seal is never as good. So it's better than nothing, yes. I think you need to have some other covering on the person's face at the very least around the supraglottic, so to make sure you don't have any further spread of aerosol.
Yeah, and there are pre-hospital crews that use the supraglottic airway, and the recommendation is to either put a towel or cut a hole in a surgical mask and put it over the supraglottic to capture aerosol that might be generated. But it isn't a complete seal like the intubation is.
Great. Okay, and then one very last one, and then we're going to wrap it up. But how about a huck towel with Kelly clamp for neck covering?
You're on your own.
Great. Well, listen, to the both of you, thank you so much for your infinite wisdom and work on this. You're really regarded as two experts in this field, and it's really a privilege to have you take part in this and on a regular basis officially now. So again, we always get such great feedback from both, and deep respect from my end, and thank you so much. So with that, we'll call it a night. It's a wrap, and thank you very much, everybody, for tuning in. Bye-bye. Till next week. Bye-bye.